It's our honor and pleasure to welcome all participants and especially the presenters at this first online version of our Tech Expo Tech Talks. This is really showing how important technology is, and the discussion on acceptance, we just passed that because now it's not nice to have anymore, but it's a need to have technology. So that's all about our meeting will be about technology. So I would like to ask Carlos to give a sort of an overview of the goals and aims of our meeting.
Yeah, normally we've been working already for a few years with the Tech Expo and Tech Talks, and before that always related with technology. And what an incredible moment is this for technologies that have been used in our education and in dentistry. If we think together, the dentistry has always been really innovative, and dental education has always been upfront in development and innovation. I think the last and the current situation regarding the pandemic and the COVID-19 has offered us an opportunity to use it even more and to be able to try to keep our lectures and our work in a different way, which is only possible, has been only possible through technology. We know for sure that all schools and every teacher, dental teacher, has been working with a lot of new things, and how interesting is it to share with everybody and to give a platform such as this one, just to try to inspire each other and to share mostly what we've been doing since March, when this whole situation started. So we're really happy to be able to gather all participants and also our speakers and our partners who will be sharing with us their experiences during the lockdown and this COVID-19 period. We have several schools with us, and we will be, without further ado, just starting with the presentations. Our program today will include 4 presentations, academic presentations, and in between also 2 of our commercial partners will be presenting also their opportunities and technological innovations that we could be using for during this difficult period, but also afterwards. So again, thanks everybody for joining. I hope, I wish you a lot of pleasure with this session, and let's go further with our first one.
Okay, so it's a pleasure to introduce to you Dr. Argiro Capodella, who will be our first presenter from the Medical School of Athens. And she will present on whether dental schools are prepared for the new normal. So Argiro, the floor is yours.
Thank you, Majoke. It's not actually the Medical School of Athens, it's the Dental School of Athens. So can everyone see the screen, the PowerPoint screen?
Yeah, we see it and we hear you perfectly.
Okay, thank you. So thank you for inviting me into this webinar and giving me the opportunity to discuss about the dental schools at large and how they coped and how well they are prepared to deal with the challenges nowadays and ahead. So the theme of this presentation is, are dental schools prepared for the new normal? Organizational and educational challenges in integrating E into the curriculum. When I started putting together this presentation, I did a quick search on the Wiley publishing editors, and up till now, there are almost 4,000 publications having the words COVID and e-learning as keywords in them. Most of them, of course, are examining the results and students' satisfaction of the e-learning courses that were implemented in dental schools, medical schools, any kind of university level institution. Some of them reported satisfaction, some not as much, and it's one interesting publication that appears underneath this slide on the evaluation of technology-based learning by dental students, in which only 50% were satisfied with the e-learning programs. And also almost 50% had low or basic computer skills knowledge. Soon after the pandemic started, ADEE compiled a team of educators and academics and responded to this with the results of a questionnaire that was intended for the dental schools in Europe and beyond to evaluate and register their response to the COVID-19 pandemic. Results, in a nutshell, are that there was no clinical education during that time. 90% of the teaching went online, and I have a question on this. Were these material ready already, or did they develop them in a couple of days, which is impossible if you want to have quality online content? 70% postponed clinical assessment and 50% chose to perform online exams. Considerations and future implications included questions about the quality of clinical education and how clinical competence assessment can be performed through the online methodology. Also, what implications will there be for the well-being of students and staff? European and international cooperation was needed. E-learning and blended learning are likely to increase in the near future. Infrastructure of clinics must be performed, and also what will be the impact on learning of the new methodology. On the other side of the Atlantic, similarly in North America, there was a commentary published in the European Journal of Dental Education, and the results were that there will be a definite impact on patient care, education, research, and financial resources of this situation. But also there were some interesting positive outcomes that were identified, such as that the dental education community was more connected than ever, increased knowledge sharing and research collaborations during this time. Also, we gained valuable experience in innovative educational methodologies, and we developed and shared support resources. A strategic approach towards implementing e-learning or blended learning in a dental school includes several key factors in order for it to be successful and result in a quality education. First of all is the institutional vision and strategic goals that have to be developed and communicated to all personnel involved, such as faculty members, administrative personnel, and students, of course. Leadership has to be supportive for this endeavor. The university, the dental school, must identify its strengths and weaknesses against the goals set. Technology infrastructure must be evaluated and upgraded. Human resources must be also taken into account and whether any new persons are needed. Financial resources and constraints. Partnerships and collaborations must be established and acted upon. Also, evaluation of this implementation and sustainability for the future. Both top-down and bottom-up approach are highly recommended to implement this methodology into the institution. Key barriers include physical and technological infrastructure, funding, of course, staff training, and course development must be underpinned by sound pedagogy, which is a challenge. Let's talk about 2 or 3 elements that were mentioned before. Technology infrastructure, for example. What questions must be asked before the implementation of an e-learning program or courses? What kind of infrastructure is necessary for the specific institution? what is currently available in the market? What kind of software should be developed? Should it be purchased, in-house, outsourced, or open source software? Is the technology that is going to be purchased or developed scalable as demand increases? Are staff and faculty familiar with this technology? Do staff and faculty understand how students should ideally interact with it? Do students know how to interact with teachers and fellow students online successfully and with meaning for their education? Second element is staff training, which is of utmost importance. Professional development programs must be developed to address technical and educational aspects of e-learning. Redefinition of teachers' roles. Teachers must learn to facilitate students' learning and be answering their questions and facilitate the cooperation between them and between the fellow students. Proactive involvement of teachers in the design and implementation phases are highly recommended because it creates ownership of the final product. Also, ongoing support systems to address faculty's questions and whatever they want to be supported upon. To address staff training and the overall implementation of the e-learning methodology in an institution, it is recommended that the specific person is appointed, which could be either a staff member, which can be an e-learning champion, or the institution could engage an external collaborator, an e-learning consultant, to coordinate the transition process. The third very important element of the e-learning implementation in the dental school are the partnerships and collaborations that have to be developed before and throughout the implementation of the methodology. This could enable sharing of knowledge and good practices, sharing of costs for hardware, also development of joint programs, joint e-learning materials, collaborations for research, creation of management systems and applications, and also institutes could collaborate with technology companies to develop widely used courses such as the MOOCs or the open educational resources. Also, academics collaborate with their colleagues, instructional designers, computer experts, etc. This is a humoristic slide which illustrates in a nutshell the two elements of the e-learning implementation. One is within the institution, which is the red cycle in the middle, and the key aspects are communication, identification of resources, and implementation of the e-learning methodology and assessment. And the circles outside are the cooperation and relations of the university with external institutions, and they include networking, cooperation, identification, and sharing of knowledge and resources. The final slide should be in the beginning because it explains what new normal means. But I chose to put it in the end because I think it's very important to clarify and maybe think about that. What is the new normal for the universities and the dental school and educational institutions? In my opinion, it's restructure of infrastructure. That means physical and technological infrastructure to address the challenges of e-learning and other similar methodologies. Also, innovative solutions must be developed. Increase of the e-component is foreseeable for the future. Development of new educational tools, increased collaboration within the institution and also outside the institution, and also sharing, and this is very important, of resources, knowledge, best practices, and creation of content that is widely distributed through open sources. And all this, I like to call it flexible education. And I think, in my opinion, that in the future, education, particularly tertiary education is moving through flexible format, including all the above. And the characteristics are that this education is responsive, open, virtual, interactive, and tailored. Thank you very much.
Argiro, thank you very much for your nice presentation. I think it's really a new mindset that we are looking for. And the idea of flexible education and restructuring infrastructure is a very nice way to look at it. So we will put the questions forward to the last 5 minutes of our meeting, and we'll go on with the next presentation. So thank you very much.
Thanks, Argiro. And we will move fast to our next presenter. He's Philip Kansov from the University Medical Center in Göttingen. And the title is Remote Teaching in a Preclinical Phantom Course in Operative Dentistry During the COVID-19 Pandemic. Philip. We're seeing your presentation, but we're not hearing you, Philip.
Oh, okay. Sorry.
Yeah.
So welcome. Hi.
Introduction. Hello, greetings to everyone. I would like to present our experience of remote teaching theoretical knowledge during the COVID-19 pandemic. As you all know, dental education contains both teaching theoretical knowledge and training of physical skills. Theoretical knowledge is usually taught in a large group setup, for example, lectures, which allow for a direct interaction between teachers and students. For training of physical skills, dental simulators, phantom heads are frequently used, which are usually located within the dental school. So during the COVID-19 pandemic, we and you probably too experienced a number of difficulties directly impacting on the way we educate our students. Most severe, on-site teaching activity was suspended and students were not present at our dental school. Therefore, a new teaching curriculum was required. And we developed 2 phases. So a first part of distance education, which took 11 weeks. We started with distance education and students were not able to enter our school. And a subsequent phase of on-site education of physical skills, which took 10 weeks. So overall, the curriculum was extended from the usual 14 weeks to overall length of 21 weeks. For the distance education, we recorded podcasts of our PowerPoint slides and allowed for interactions by weekly video meetings. During on-site education, we took measures of physical distancing to allow for our physical teaching. At the beginning of our curriculum, we faced a number of uncertainties. For example, distance education has never been used before at our dental school. Therefore, both educators and students had no previous experience with distance education. And students' acceptance and effectiveness of distance education was unknown to us. Also, the future development of the pandemic, overall feasibility of our concept was still unknown. So the presented data of these slides is based on our retrospective analysis, where we assess the acceptance of podcasts as a new teaching format. We analyze the use of podcasts by our students over time. And we linked usage data with the results of the final examination within our preclinical course in operative dentistry. Now let's take a look at the results. In total, 33 students were enrolled in the Phantom course and participated within this curriculum. A total of 29 podcasts covering 3 main topics were produced and made available via an open source learning management system used at our university. 3 podcasts were uploaded per week, and students were able to view these podcasts on demand and off campus for an unlimited number of times. On average, the length of podcasts amounted to about 23 minutes, and 24 students viewed and accessed our podcasts on average. These students who accessed our podcast viewed each podcast about 6 times, so much more frequently than they could have accessed physical lecture. Podcasts in cardiology, restorative dentistry, preventive dentistry were more often accessed, viewed by more students than podcasts within the other topics. And at the final examination, we noted that items in periodontology showed inferior results compared to the other 2 topics. Finally, this graph displays the number of podcast views over time. During the phase of distance education, here on the left, shaded in red, we see an almost linear trend of podcast views over time. And podcast accesses declined during on-site education, displayed in blue, and again increased prior to the multiple choice examination, which was set at the end of the curriculum. Now let's discuss a few aspects of our teaching curriculum. As you noticed, podcasts were kept shorter than conventional lectures from pre-COVID-19 times, because it is known from literature that students' attention is decreasing after only 10 minutes. And regarding massive open online courses, videos are recommended to last between 6 and 20 minutes. As almost all of our students use podcasts, we can conclude that podcasts show a high student acceptance, and only 4 students viewed not a single podcast. And again, students viewing podcasts access each podcast multiple times more frequently than they could have visited a conventional lecture. Regarding the podcast usage, we have seen that podcast usage and access numbers showed a linear trend already at the beginning of the curriculum. So we concluded that podcast viewing was mostly due to intrinsic motivation, but also the final examination triggered an extrinsic increase in podcast viewing. And finally, the results of the examination were comparably regarding difficulty of the examination to those from the pre-COVID-19 times. Because of these results, we concluded that distance education seems to be effective. So based on the presented data, we concluded that distance education using online podcasts seems to be a viable way of teaching theoretical knowledge, at least in undergraduate dentistry. Podcast usage seems to be linked to examination results, and in the future, podcasts should be made available to our students in addition to conventional lectures as soon as the regular curriculum can be resumed. Okay, so thank you for your time, and looking forward to your questions at the end.
Thanks a lot, Philip. We will be having some questions at the end of the session. In any case, it's really impressive to see the growth of the use of your podcast in your side. It's really interesting to see. So thanks a lot for your presentation. We'll be coming back with questions at the end of the session. Let's share the program again. Just 1 second. There you go. we will be having our first corporate partner now, and welcome then James Markey from HRV Simulation. Very, really nice that you're also there sharing your new developments. Welcome.
Hi, Carlos. Thank you for that. Let me just grab my screen up. But it was lovely to hear from Agiro and Philip, and great to hear about the technology that's used on the ground as well, using things like podcasts. It's fantastic. And no one needs to worry. I've not got a huge sales pitch or anything for you. It's very much to say that we're all in this together. You know, there's a huge boom on simulation now, and we've seen very much since the end of the first lockdowns here in March, we've had about 5 times the traffic on the website. So we can see that simulation is becoming something that's vitally important, and we're all in this together. So the question is, how can businesses help in this situation and going forward as we hope that we come out of it? So to share with you a few things that we've been doing at VertEasy, we've been helping with free remote access to the simulators, to all the teacher applications and the installations as well. Our first flight planned was actually in April to go to China to do an installation. But obviously since the lockdown, we've actually put in place some programs so we can do the installations at distance and make that easier so that the universities that need simulation can still get to them. In collaboration with University of Sheffield, we've been working on some new exercises which actually allowed qualitative feedback. And if you saw one of the ADEE webinars last week, you would have seen a little introduction to that as well. So we've made that available to all the universities now that have VertEasy, so their students can actually do exercises that have some automated feedback that's more qualitative. We also were very lucky to get some investment from Epic Games, the guys behind the Unreal Engine and Fortnite. So with them, we've actually been working on bringing it to the VR headsets as well, and making, again, that the new scene and everything available as we work through it to the universities that are with us. And then lastly, affordable quarantine haptics is something we've been looking at. So the universities where they've got students who are at high risk due to medical conditions, etc., we're sending out the first units just before the end of the year. And the idea is that the students that physically can't even come into the simulation suite will actually have some haptic devices at home so they can still get some practical use out of their time, which for us is really exciting. But like I said, I haven't got a huge sales pitch or anything telling you why you should choose VertEasy over everything else, because this really is a period where simulation is going to help people learning and help universities teach. And I'm really excited actually to pass you over to Carol next, because one of the things we want to work with is working with other simulation companies to actually work together. And it's really exciting as well with Carlos and the guys there from ACTA, because you'll see behind them, they've got a Simodont machine and a SimDecare machine. And we've got universities now which have both Simodont and VertEasy, and in the future, VertEasy and SimDecare, and maybe one day all 3 in a room. So we really want to work together on making them able to communicate with each other, share exercises, and share the parts that you love from one company so that it'll work with the others. But that's everything from me. If you have anything after the webinar, you're welcome to email me with my email address that's on the screen. But otherwise, thank you very much. And back to you guys at ACTA.
So James, thank you very much for your nice presentation. And we all agree that we should bind and do things together and cooperate on how to solve the challenges of the future. So I would like to give the floor to Karel, who also as a partner will share some information from the partner side on technology and what's happening. Okay, so thanks again. And Karel, the floor is yours.
Yes, Thank you very much, Marjoke and Carlos and James, for the nice introduction. I will indeed come back to the open interface topic that you just touched upon during my presentation. Well, SimToCare, we built haptic simulators, and we try to help improve the professionals improve the quality and efficiency of education and care. And I will focus specifically on what we can do in this period of online learning, and that you can still practice the hand skills and develop the competences in practical skills, related competences as well. Just a short introduction, the next generation dental training simulator that we've now developed, it retains the high fidelity haptics, which we're still expanding to create a realistic feel. We added the phantom head, which is a very strong element, I think, of the traditional phantom heads for proper support with the upper and lower jaw and the plastic teeth for finger support. We mix that with virtual objects, so it's mixed reality. I use auto stereo display. That's also something new available now, that you do not have to wear glasses, and you can actually work with loops quite comfortably as well while working with a simulator. The visual is co-located near your hands, and you can also see your hands because it's mixed reality. You do not only see the virtual objects like the teeth, but you also see the hands and the real support points for your fingers. It's a larger workspace now, which means we can also support implantology and other procedures where you need to access both upper and lower jaw while you're exploring the full jaw. And the objective is to try and simulate as much as possible a real patient treatment. So the workflow that you normally have with a real patient, use all the tools that you use before you see the patient, and also export the results such that you can also learn to work with that software to evaluate a patient treatment. And well, why use a dental simulation, and why especially now? Well, it's a safe way to practice before seeing patients, which means preclinical practice, but also just before you see patients, so to prepare for a patient treatment. And at the moment, sometimes you have to use it because you cannot see any patients. So it's also the only way sometimes to practice at this moment. Well, mixed reality simulation has the advantage there's no aerosols. So one of the risks I understand with real handpieces is the generation of aerosols. And actually, King's College have developed with NSK a handpiece which generates much less aerosols and with big water drops for cooling. And we use the simulator now for retraining dentists to use this new handpiece. So it also helps with the prevention of generation of aerosols in real treatment. Well, students, if they use it at this moment, they have to come to the university, but you can put it in a separate room, and it's easy to sanitize, disinfect after usage. And the students can use it from basic skills to the most complex cases. So it's usable across the board. So we see that actually at the moment it's much wider used than before, not only for the first year, second year, but up to the very end of the curriculum. Advantage of a simulator and also the software we added recently is that you can not only store data, you have objective assessment, but you can also remotely supervise and monitor what's happening with the student, and you get the results also remotely available. Just an example here. So you see the simulators at King's College where they use it for the NSK handpiece retraining, but also across all the years. It's very intensely used at the moment. On the right hand, you see an example of remote support, and in this case, UCLA, where we can see what's happening. And on the top of the screen, you can see 3 people also witnessing the session. And you can communicate through the through the speaker of the simulator to guide the students. Here you see an example of the procedures that are in the simulator. In this case, it's an endodontic access, one of the chapters. So we're trying to expand more and more the number of procedures. And at this moment, there's totally new needs like waxing procedures, dental charting, which we're now developing with the users because it's very difficult to access the labs for dental waxing. And so we try to make it available in a different way. As I said, it needs to simulate the whole workflow. So we need to be able to import all the open scan formats, STL, PLI, ICOM, such that you can, instead of working with a real patient, at least use realistic models, realistic scans, such that you can come closer to the treatment of a real patient. And then after treating the patient, the virtual patient in the simulator, we can export the results. So it's like taking another scan of a patient and use tools like E4D, PrepCheck, any tool that can read back the STL or PLI and perform objective assessment or judge if you've treated the patient well, like with the same way you do it with a real patient. And our aim for the future will be to keep pursuing this open interface strategy. And as James said, he's got also some very nice tools for editing models. And well, why not allow the universities to work with a mix of tools? And that's why this open interface strategy, I think, is very helpful.
Perfect. Thanks, Carol. Carol, we have to interrupt you, sorry, because of the time. We will, of course, be sharing the rest of your presentation in the website afterwards. So thanks again for your time and for being here. Thanks a lot. Really interesting.
Okay, my pleasure.
We will be going back to our main program. And for our next presenter, who's Michael Botello from the University of Hong Kong. Michael, welcome. Nice to see you.
Fantastic. Thank you so much. I'm just, yeah, the layout's slightly different. Here we go. Okay, I'm getting there. That's the right one. Share that. Put that on there like that. How's that? Can you see me now?
Perfect. We see everything.
Fantastic. Lovely, thank you so much. And thank you to colleagues in Southeast Asia, I think from Malaysia and Thailand who've joined along. I hope you don't mind, I extended that invite to some of the colleagues around here. So thank you to Mallorca and Carlos for inviting me to talk about this. I've developed a particular interest about supporting clinical skills learning, both online and in class, and I'd like to share that with you. And to give a kind of framework to the presentation, I'm going to talk about what clinical skills we can be doing online and doing it better in the classroom, why we should be doing this, that's got to do with the clinical transition gap that there exists in healthcare, and also the ethics of maybe what we should be doing. And to highlight this kind of approach to learning, I've chosen two particular pedagogies. One happens to be a dialogic video called Observation of Videoed Expert-Student Dialogue. And the other one happens to be something I call Synthetic Clinical Experience. So what are the sorts of clinical skills that we can be helping students with, either in this time, but beyond this time? We can do it when we're in the class or doing things online. We've obviously got the hard skills that you can see there that we're most familiar with. But it's also the soft skills that are very important and I think very much overlooked. And we've missed out on these things, and you can see some of those there. But really those two, the hard skills and the patient-related HOTS, or the higher order thinking skills, they're very much interrelated and interconnected, but we often don't think about them in that way. And so one informs the other, and they're equally as important. And we can do a lot of these online and in the class in helping our students learn. Why do we want to go about this particular approach in increasing our clinical skills preparation of our students? Well, I was very kindly invited by Carlos a number of years ago to participate in a special interest group. And the outcome of that presentation and the paper was there was a realization there's this gap in clinical dentistry. And as I've mentioned, it exists in healthcare, in medicine, nursing, and physiotherapy. And when I had that highlighted to me, it made me reflect and think, do we have that problem in Hong Kong? And so when I came back after a period of time, I did a qualitative analysis. I looked at the issues that our students were facing. And lo and behold, we identified, yes, overall, there is this transition gap. And it is based on hard skills and soft skills. We know this, and it's important that we do something about this. And at the moment, we're not. I think this is the greatest gap in our dental curricula and in healthcare at the moment. And that is, we're not supporting our students to prepare them better for clinical practice, and we need to examine that. Because of that, we're not giving patients the most prepared students that they deserve to have treating them. This is something I believe quite passionately. It's something I've learned about over a number of years. It's quite new, it's a realization, but it's something that we must look at and focus on in what we can improve on for our students and our patients. So how do we go about doing this? Well, if we're going to use a framework, there's obviously Bloom's, but Miller's applies here with regards to the assessment pyramid or the learning pyramid. And what I've identified is there is a gap not only in the clinical transition, there's a gap in Miller's pyramid. We've got the knows, how, up to the does. The does happens in the clinic. And you're probably familiar that generally the shows how is a kind of like procedural understanding about how things are done. It's a kind of competence at a psychomotor level in the sim lab. But then there's that gap to the real world problem that we have that is much more different, much more challenging, cognitively demanding, with things that can't be anticipated. That's the gap we've got in our curricula at the moment. And so therefore, what I'm proposing is that we need to fill that gap. And we need to give experience. It's a synthetic kind of experience. And it's to help students with their cognitive and clinical decision-making skills. And so therefore, I've added into this pyramid an observes how and manages how. What I'm going to focus on is the manager's how, and this relates to the higher order thinking skills that you can see there, ranging from diagnosis all the way to reflection. And there are two elements I want to share with you about how this manager's how can be used through a pedagogy. One is through the expert student dialogue video, and the other is through synthetic clinical experience and the use of worksheets in a flipped classroom. Notice at the moment I'm talking pedagogy. I'm not talking about lecturing. I'm not talking about online, because it's the pedagogy that's most important and its alignment to what we're doing. I started off, as maybe some of you might be familiar with, recording these videos of when students had a case they were planning on the clinics. I taught them the bridge course in the sim lab. But when they went to the clinic, they realized there was a gap and they struggled with that. They would come to me with their study models and radiographs. They'd come to my office. We'd go through a Socratic dialogue and a chit chat about it. I talked them through that learning episode. They'd leave, but the rest of the class weren't there. They missed out on that very bespoke student-centered problem. So I started recording those, and initially I called them a communal consultation video. Over time, I started to record any of these student-teacher dialogues to capture particular episodes of learning. This one happened to be on a student's iPad. 10 students came into my office wanting some questions. We went into a seminar room. I recorded the iPad and our discussion and dialogue. You can't quite see there, but admittedly it was around exam time. And of course that drives the learning, but there were 214 hits on that video to do with the questions and answers. I've also expanded it for competence assessments. We do a bridge for our clinical competence assessment. Students do a case presentation before they treat the patient, and afterwards they do a self-evaluation at the end of the session. I've recorded those before and after segments to help prepare students for when they're going to do this high stakes summative assessment. They gain from experience, learning, they get assessment literacy, and they get confidence having watched these videos. This is backed up by the analytics of how much they watch these videos in preparation for their learning. I don't require them to watch it. They know it's there, they know it helps them, they consume it. The other expert student dialogue videos I do is my debriefing for the flipped class. This again goes through the question and answer dialogue that I record for students to watch to help them for their revision. And the last one I record is chairside clinical problem solving, where a student is doing something and I capture that for other students in their year and subsequent years, because what this is, it's very environmentally friendly. It's a reusable teaching dialogue. Once it's there forever. Moving on to the flipped class, this is the second pedagogy. I have elements of what I call synthetic clinical experience. Most of my teaching and learning is done in the simulation laboratory. I use worksheets, I don't do lectures because I think that's a rather passive monologue way of stimulating learning. So the students get the worksheet ahead of the class. Some of it is rather low level, but somehow on Bloom's taxonomy, you've got to make sure they understand the basics. But we slowly move up. We use pictures and problem scenarios for them to think about things so they can move up Bloom's taxonomy and they start analyzing and thinking about the things. We get them evaluating tooth preparation. So they learn judgment skills. They learn judgment of features of quality, what's good, what's not good, and what do they need to do to that to correct it, to make it better. That in a way is a clinical judgment skill. So that is also synthetic clinical experience. In the simulation laboratory on the worksheets, we also go through scenarios like this, where we get students to problem solve, what are you going to do here? How might you handle that? So that becomes a synthesis and a treatment planning modality within that framework. So in summary, I've highlighted two pedagogies that we can use to support our students in this gap that we have in our clinical transition. I think it's a very important one we need to look at. And I feel that we're educationally bound to prepare our students better for clinical teaching. I've realized we have that in our curricula, and that's something that I'm now currently working towards to help prepare our students better. Thank you very much. I hope that's been of interest. Thank you, Majorca and Carlos.
Hey, Michael, thank you very much. I think this is not only in times of Corona, but also in the normal world, really a challenge, the step from preclinical training to the clinics. So before we have the general discussion, I would like to go to our last presenter. That is Tahir Hamza from Tufts University School of Dental Medicine. Tahir, the floor is yours.
Thank you so much. Hi everyone, I'm Tahir Hamza. I'm a second-year Master of Science candidate at Tufts University School of Dental Medicine. Today, the theme of my presentation is Remote Development of Clinical Competences, and the title is We Transform Dental Education, Level of Evidence for Surgical Simulation. The outline for today's presentation is, first we're going to discuss the transition to remote education. Then we're going to discuss how did we make that transition, going ahead with which educational tool helped us make that transition. And then we'll talk about the level of evidence and the theories supporting the educational tool. And we'll finish our presentation talking about the significance. Beginning with transitioning to remote education. The COVID-19 epidemic forced a rapid transition to remote education. The DMD students were exposed to periodontal surgery in the past during their periodontal rotations, during their periodontal surgery program, and the lectures. COVID-19 shutdown caused several changes in the curriculum. Rotations were replaced by virtual rotations. All procedures, including surgeries, were temporarily halted. Lectures were administered remotely. We had to come up with ways how to transition our rotations virtually. The DMD third year and fourth year students spent sessions in the postgraduate periodontal clinic observing and assisting surgical periodontal procedures. The problem was that due to the pandemic, the clinics were closed and the rotations were cancelled. The faculty had to come up with different ways to transition these rotations in a virtual environment. I'll explain them going ahead with the help of a logic model in the next slide. When we talk about logic model, we're talking about the assumptions, the planned work, and the intended results. Our assumption or the aim was to teach surgical skills in a virtual format considering the pandemic. What were the resources which we used? We used educational technologies such as Zoom. For content delivery, the faculty and the residents presented case presentations. Faculty received training prior to delivering the content virtually, and the touch surgery application was used as a portable simulator, which is the educational tool. What were the activities? There were synchronous and asynchronous sessions. In synchronous sessions, there were live lecture capturing, and in asynchronous sessions, the students were allowed to download the app and play around themselves. The knowledge retention of the students is tested with the help of a pre and post assessment test. And we also have feedback from the students available. The outcome was that it turned out to be a very valuable experience for all stakeholders, and the students' knowledge showed improvement. Going ahead, we'll talk about the educational tool itself, which is called touch surgery. Touch surgery is an academically validated interactive surgical simulator that provides a realistic and detailed guide to every step of a procedure, so you can learn, test, and rehearse for surgery anytime, anywhere. There are currently 200 plus surgical simulations across 17 specialties, including dentistry and oral surgery. It is used as a cognitive task simulation and rehearsal tool. It is used in surgical resident training and assessment. And the app was first developed in 2010 by Digital Surgery Limited, which is a London, New York City, Sydney, and Oakland-based health technology company. All these institutions are currently using the touch surgery application. Touch surgery has gained widespread acceptance in surgical specialty training as an interactive simulation and rehearsal tool. There are currently more than 1 million healthcare professionals around the world using touch surgery application. Considering dentistry itself, we have more than 60,000 users in the United States itself. Going ahead, we'll talk about what is the level of evidence supporting touch surgery. We saw that a lot of users are using touch surgery all around the world, but our question was, what is the level of evidence? We took help of an expert librarian and did an intense literature review, and we were focusing on randomized controlled trials. When we were looking at the outcomes reported, some were focusing on validation, the others were focusing on knowledge retention and cognitive skills, and some on impact on patient care. These were the outcomes reported. Touch surgery has been validated by all these studies in terms of construct, content, and face validation. Statistical significance has been demonstrated in all of these studies, proving repeatability of validation, irrespective of the specialty, location, or the procedure itself. We'll talk about what are the theories supporting touch surgery. What is the pedagogical principle that supports the learning with simulators of our students? There are few theories supporting touch surgery, but we'll discuss some of them. Cognitive task analysis is one of them. CTA is the underlying methodology used in the touch surgery app. Surgical procedures on touch surgery are created with leading surgical experts in the field using a CTA approach. This creates a map of an operation. The medical visualization team layers this onto a virtual reality patient. CTA helps you unpack the thought processes of experts so you can teach them to others. CTA breaks a procedure into its cognitive steps with particular focus on decision making. Constructivism is another theory supporting touch surgery. Without positive reinforcement, research shows that after 30 days, only 10% of the learning acquired in a passive state is retained because learners don't apply what they have learned. Linking new knowledge to prior knowledge is explained in the theoretical framework of constructivism, which attributes learning to the interaction between new knowledge and the already existing schemas in long-term memory for the construction of new schemas in a process known as elaboration. Now we'll talk about what's the significance of this. How does this help in dental education? Recent studies have shown that simulation training improves performance during real cases with fewer errors. Mobile simulators offer a useful adjunct to enhance undergraduate clinical skills. As compared to current gold standard revision resources, they have advantages in terms of cost effectability and practice flexibility. Perception towards surgical simulation by residents is predominantly positive, with most residents appreciating that simulation-based training is essential and should be mandatory in current residency programs. Now we'll go over to the live demonstration of the app itself. As you can see, I have my phone here, which is connected with a cable to the laptop, and that's how I'm going to share my phone screen. Now you can see I'm inside the app. This is what the app looks like from inside. Here are all the specialties, and here you can see that a lot of them are especially for medicine, not so much for dentistry. And then if I go into dentistry, we will see that currently we only have 4 modules available for dentistry. We will go into one of them. Let's do bone level implant placement. So here you can see that there are 2 modules, learn and test module. I'll start with the learn module. Here you can see at the bottom side of the screen, you have additional information in terms of how to position the patient and all that. Patient is positioned safely in the chair. What are the first steps we do before we start the procedure? We are retracting the cheek with the help of a retractor, and I'm using my finger to do that. If you want to find out more information regarding it, it's in the bottom of the screen. Then we are starting our procedure. We know that we have to create a mid-crestal incision first if we want to place implant in that area. Then we'll do a circular incision around the molar. So all of these steps we have to do one by one. Then we have to do a similar circular incision for the premolar area as we did for the molar. These step-by-step procedure will go on till we finish placing the implant. However, due to time restriction, I cannot go over the whole module. Now we will go into the test mode. So you can see how exactly the questions are coming up. For a student, for every single step, they will kind of have the questions. So the first question is, if the clinical and radiographic evaluation has confirmed that implant placement will be straightforward, a simultaneous bone augmentation procedure is not necessary. It even tells you if it's a correct or an incorrect choice with the explanation. They have questions related to what you have learned in the learn mode.
Okay, I'm sorry, Tahir.
Procedure.
Tahir?
This brings me...
Tahir, I'm sorry to stop you, but because it's 2 o'clock or 1 o'clock, we need to finish. So, but maybe there are people who can join further, so we can do it after 1.
Sure.
So at this moment, I would really like to take the time to thank you all very much for the presentations and for for the fact that you were there. So also all participants, thank you very much for joining this session. And we were thinking about repeating a comparable session, not in a year, but earlier, maybe in a few months. So to providing the opportunity to have the discussion, because now we have the presentations, but we really need time to discuss and see where we can find each other. So for this moment, we would like to close the official part of the session. So also on behalf of Carlos, thank you very much. And we would like to go on with those who have time to go on.
Yeah, we were able to keep around 60 participants until now. So we know everybody has different obligations. So for those who must leave, thank you very much for joining. We will be organizing something similar very soon if ADEE agrees, of course. And we will move on with our questions further. So please, the presenters, if you're able to stay, please do, because there are plenty interesting questions for you. Okay, so we're watching here. I'm sorry, we're reading here the questions on the chat. I think Judith, Francis were also taking the lead for the questions.
No.
We hear you, Judith. Actually, we don't.
Okay, can you hear me now?
Yeah, we do.
Okay, hi. I think there are just two questions here for Philippe. And the first one was, what was the content of these podcasts? How did they help the students in learning clinical skills, or was it only theoretical? Are you there,
Yes.
Philippe?
Yes, I'm here.
Yeah.
So all the podcasts which were uploaded to our students only contained theoretical knowledge, but we used podcasts with clinical procedures during on-site teaching. So we had videos containing text content for our students, which could be accessed during on-site teaching. But all the podcasts uploaded online were on theoretical knowledge only.
Okay, thank you. And there was another question as well for you, Philip, and Göttingen University. Have you given synchronized lectures besides podcasts as well?
So at our department, we did not. We only used these podcasts and had live interactions, video meetings using Zoom conferences. So that was some part of synchronized learning, these weekly Zoom meetings. But all the podcasts and the lectures were recorded.
Okay. Okay.
Perfect. Thanks.
There's another question here from Barry Quinn. When will artificial intelligence be added to haptic simulators so that we could, for example, get students to ask about a medical history from a virtual patient?
So I think that's an open question.
Yeah.
Yes, so somebody wants to take the lead in this question? Maybe Michael?
Or James.
Or
yeah,
James.
Perfect.
Well, I was just going to say that the prototypes are here already. From a technology point of view, for the simulators when they be implemented, it's not in the very short term. But if you ever are interested in it, we have worked with Lab for Sims in France. So we actually have a prototype already with the simulator, where you have a patient come in, you speak, and then the patient responds, and it's the sort of pre-steps before going into the simulation when you're talking about medical history and the sort of things you should be doing for the planning stages.
I think that's one very interesting aspect of what we're needing at the moment, with not being able to get in contact with our patients. But we still have the other aspect, which is actually the performing a procedure with real patients. And I think that's actually what Michael named the last gap in dental education, just when we are about to start working with the actual patients. And I saw in Tahir's presentation that he mentioned mobile simulators. Can you explain a bit further about that?
Yes, sure, Carlos. So the mobile, it's a portable simulator called Touch Surgery, and it's freely downloadable on Apple and Android devices. What it really does is that it helps you practice or rehearse surgery before you actually perform them on a live patient. So it actually reduces the risk of complication. For a student who is first time performing the surgery, he gets a rehearsal before the patient. The patient care is also improving. And the most important part is that when the students perform it on a simulator with their own hands, it actually increases their knowledge retention.
Thanks, Tahir. I think it's, if we add to that, maybe also some haptics, and we will be moving further into a really useful way of training at home, maybe with a possible dental mobile unit for remote training.
Yeah, so Judith, are there any more questions at this moment?
There aren't. There was one earlier for Argiro, which I think she might have answered privately, and I actually can't remember it, Argiro. Was it relevant to?
I think so. It's about participation of students in the solutions.
Yes, the students' role in the e-learning implementation. I think the students' role is dual. One, they must be part of the team that will develop and implement the e-learning courses because they know best what they want. And secondly, that the students must evaluate the e-learning courses at all times. And also they must relearn how to learn because they have to do a lot of self-directed learning during the e-learning implementation. So they must clearly understand and adapt to this.
Thanks, Argiro. Yeah, I think I have only a question for Michael. Oh, sorry, Judith, do you have another one?
There's one more on the haptic
Perfect.
simulators. Will they be able to fill the dental cavities with a virtual composite material?
Carl here from SimToCare.
Yeah.
Yes, you can indeed drill a tooth and then fill it with different filling materials, and then after filling it, refinish the tooth. So yes, that's possible.
Nice to hear.
So I understand that there's a button, just pressing the button to fill it, but the finishing is the part that can be trained.
Yes, it's possible also to fill it, but it's the feeling of the filling is not the same as in reality. It's really currently about the finishing of the tooth after the filling, to be honest.
Okay, thanks, Carol. I think there's still work to be done in that regard regarding the materials itself, because they need to be improved in the filling. But it's nice to hear that they exist already as a begin. I think we are now over time, of course, but I would like to ask Michael Botello. Are you still there, Michael?
Yes, I'm still here.
Oh, great. Because I'm not sure if you were able to see that if we combine every presentation we saw today, we're actually tackling the gap problem that we've worked on together as well. How do you see after these presentations of today the problem of the gap moving forwards?
Oh, good question. I think each context has its own gap, because courses will have strengths and weaknesses. So you've got to evaluate what your strengths and weaknesses are. And I do think you've got to make sure that you target that, because there are so many different levels that we're not preparing students. And it has to do with just the way that we accept the fact that when you take the student from the sim lab to the clinic, there's a gap in their communication ability. I was chatting with students today. Do you feel confident chatting with patients at the chair side? Of course they don't. Do you feel confident with the new environment that you're working in? They don't. Do you feel comfortable in dealing with patients who have different medical issues? And so I think we've landed ourselves in a rush to get students onto the clinic so soon because we think that's good, and I've been guilty of that. I always used to think, get the students onto the clinic as soon as possible. And I actually think that's wrong, because it's putting students under pressure in situations they're not comfortable with. It takes us longer to teach those students at the chair side, and it means patients aren't getting the quality of care they deserve. So I think we've got to think a bit like aeronautics and training pilots. And we've got to do different types of simulation and event episodes and checklists and what if, how do you manage that before you let them fly in the plane, before you let them go onto live patients. So I think we've got to reinvent what we're doing to better support our students. So I think what we're talking about at the moment is going in the right direction, absolutely.
Yeah, exactly. I think we can actually smooth the transition by preparing the student, taking a few moments before the patient to prepare the students to that, for that really stressful moment of starting the clinics. Thanks, Michael. I think Aguirre must leave us at the moment. So I want to thank you very much, Aguirre.
Thank you so much.
Yeah, thank you.
It has been great.
Oh.
Okay, so I think we will finish the session now, but there are so many things we still need to discuss. So as mentioned, we will try to organize a session again in a few months from now, when ADEE is willing to support us with that.
And of course, I think also thank you guys, everybody, for joining, all the participants as well. And I think it's really interesting, and it's such a nice learning situation for us to come together, share our experiences in these last difficult months. And I think we can agree with each other that only with this sharing, we can only move further, supporting each other and become learning from each other as well. So thanks for joining, and we'll be publishing everything on ADEE's website, the presentations and also the recording of this session. Have a nice day further today, and stay safe, of course. See you soon.
Okay, see you soon, and thank you very much.
Bye.
Bye.